a few days ago on New England Journal, the BEST-CLI study results were published, and this is fresh and new. The conclusion just came out. We know that in US and in many other countries, lower extremity arterial endo treatment is conducted by the radio interventionist. And we can see that the experts from US are all cardiovascular experts. So together with the US experts who specialize in endo treatment, we now have this online communication. I think it's very valuable. And for the Fem-pop lesion endo treatment, we can have in-depth discussion. Today, we are very honored to have Dr. Craig Walker from New Orleans to be the co-chair, and we are familiar with the doctor because he's a very famous surgeon in the world, and at a different international congress, we had the honor to listen to presentations by Professor Craig Walker, and many domestic doctors are very familiar with him. Now let's welcome Professor Walker to give us an opening speech and also introduce the first speaker. So Professor Walker.
Thank you so very much. I have three colleagues together that will be with you today. To my immediate right is Dr. Matthew Finn. And it's very interesting, you just mentioned the BEST-CLI study. Dr. Finn has just recorded a commentary, a critique of that study, which we can speak on later. But our first speaker tonight is going to be one of my other colleagues, Dr. Pradeep Nair. And do we have Dr. Nair's image? Dr. Nair should be with us. And yes, so this is Dr. Nair, and these are his credentials. As you see, and certainly these are two of my very advanced peripheral vascular experts, and we're very pleased to be with you, and particularly are pleased to be with you on behalf of Barty. When I traveled to to China and worked with Chinese physicians, I was very impressed when I visited Barty Medical, as you have many of which I wish I had in the United States. So we're very pleased to be here with you. Should I introduce Dr. Nair to start tonight's talk?
Yes, please go ahead.
Okay. So Dr. Nair was previously one of my fellows. He is an exceptional peripheral vascular interventionist. He's a cardiologist by training. And it's indeed my privilege and pleasure to introduce him to present to you tonight on a series of cases looking at complex endovascular intervention. Pradeep?
Thank you, Dr. Walker. I want to thank all of you and the organizers for the invitation as well. I'm going to share my screen, and please let me know if you can all see it. Can you all see my screen?
Yes.
Very
yes,
good.
we can see. Please put in play mode. Thank you.
Okay. So I was tasked to talk about complex femoropopliteal long lesion intervention, and it's deemed the U.S. experience. And in actuality, it's our experience. Over the last several years, having trained with Dr. Walker, I have amassed a wealth of training and knowledge on endovascular interventional care among patients with a wide host of vascular disease processes. So these are my disclosures. And I'm going to start off by discussing, we just mentioned BEST-CLI, and we have to decide when we get a patient with peripheral artery disease or critical limb ischemia on which strategy we're going to employ. whether it be surgical or endovascular. When we're dealing with peripheral CTOs, roughly 40 to 50% of these patients have CTOs who are either claudicants or CLI. And yes, we treat these patients with medical therapy, exercise programs, and wound care. But when we encounter a CTO, what is critically important is that we have to address various factors, such as their anatomical factors. What kind of lesions do they have? What are the experience of the operators doing the procedure? The patient's preference should be taken into account. What is the center's experience? Some may have better experience with vascular surgery, others with endovascular care. And what risk factors does this patient entail? So these are all important points. And when we talk about BEST-CLI, yes, this is hot off the presses. This will be a topic of significant debate, discussion in the United States in all of our meetings. And what we can see from BEST-CLI in a cohort of critical limb ischemia patients is that patients who are treated with saphenous vein conduits with CLTI had less composite major adverse events, or MAIL, versus endovascular revascularization at a mean follow-up of 2.7 years. Now, major adverse limb events was defined as amputation above the ankle or a major limb reintervention or death. And I have to point out that this difference was driven by higher reintervention rates among the endovascular group. But I have to highlight also that I think that the take-home message is that if you have a good saphenous vein conduit, that is superior to a prosthetic type of conduit. But also, I think what is important is the endovascular approach that is taken and the expertise of the physicians who are employing whatever skill or modality you choose. So let's get into the SFA and the popliteal segment. Obviously, this is a segment of substantial challenge in treating given torsional forces, compression, flexion, extension, and contraction. If you look at vessels that are bent, you can see the intrinsic challenges that we face. These are areas that are prone to restenosis, and modalities for endovascular care have to be taken very seriously as to what is the best treatment strategy for lesions in this location. If task criteria, if you go strictly by that, by the studies, type A and B look at endovascular therapy as being preferred, and type C and D as surgical treatment perhaps being preferred. But I will tell you that in our practice, based on referral patterns, based upon the fact that a lot of our patients are task C and D to begin with, and I would say the vast majority are task C and D, these are patients that we know that we can treat with endovascular therapies very successfully. Many of these patients have had failed bypasses in the past, and there's intrinsic challenges when we are faced with these patients to treat. So when we also look at the SFA popliteal space, we have our stents and conventional angioplasty. But restenosis is a manifestation of not only lesional, the binary restenosis is a manifestation from how long the lesion is. The longer the lesion, the higher the restenosis, which we clearly know. And nitinol stents are not immune to this. Drug-coated balloon technologies have improved substantially what we have over balloon angioplasty, but I will say that we are still in the process of evolution to try to get to the lowest restenosis that can be achievable. So let us talk about endovascular intervention. So first step in endovascular intervention for a SFA popliteal stenosis is to plan the procedure. We must obtain duplex ultrasound or a CTA or whatever imaging modality of choice is available to you. And this allows you to address what it should be the primary or alternate access sites for these patients. In America, in our institution, we also have the choice of choosing whether or not we want to go into an outpatient-based lab or an ambulatory surgery center or take these patients to the hospital. And I can tell you with firm certainty after our experience with our outpatient-based lab that the most complex patients seem to be well treated, better treated, given the technology that we have in our outpatient-based labs, as well as a skilled staff that is available to us who have the same mission for limb salvage. Also, we have to keep into mind the patient-specific risk factors, what type of disease processes these patients have. If they have chronic kidney disease, we may consider utilizing CO2 angiography. But for example, I will say that procedural planning is going to be important. Here's a patient that was sent to a colleague of mine. It was a 72-year-old with COPD, had severe rest pain, was referred for endovascular intervention with severe reduction in the ABIs. This patient's ultrasound showed the common femoral arteries were patent, but the patient had mid to proximal SFA disease. Unfortunately, what was overlooked was the monophasic waveforms in the bilateral common femoral arteries. They were having challenging access in the common femoral arteries, and they came from the radial approach and found a distal aortic occlusion. So understanding your ultrasonography, understanding your imaging, and planning the procedure ahead of time is vitally important. This is a busy slide, but I will say that I always utilize ultrasound-guided access for any of my procedures and utilize micropuncture. I think micropuncture is safer, and utilizing ultrasound allows for an anterior wall puncture so that if you choose a closure device at the conclusion of your case, you'll have better success and less bleeding. The most common access sites, of course, are the common femoral artery, tibial, radial. Less commonly, I utilize the brachial and popliteal, and direct stent puncture for complex disease can also be considered. Now, for most of my SFA CTOs, I will say that I do a contralateral up and over approach from the common femoral artery. I utilize common femoral artery antegrade approaches if we have distal SFA or popliteal disease, and a lot of the times if we have infrapopliteal disease below the ankle. Anatomical reasons as well. These are situations where you have no access for an up and over approach if stents are sticking in the aortoiliac segment. Retrograde tibial access I utilize for facilitation of reentry. It is a primary access site. If for certain anatomical reasons, I utilize primary access. Radial is a burgeoning area of endovascular intervention. In our laboratory, and if I have 10 cases a day, I will do 3 to 4 peripheral interventions utilizing a radial approach primary to treat SFA disease. The brachial approach, as I mentioned, I rarely use these days because of the radial approach and the surplus of equipment that is now starting to develop. And popliteal and direct SFA sticks are possible, but less commonly used. After I get access, we want to ensure that we have good access, and I always do an angiography after I obtain my access. You look at why do you need alternate access sites? These are certain reasons. In the United States, we have a very high population of obesity. Groin access sites can be challenging. Tortuous iliac anatomy. Patients with aortic endografts, bypass conduits, or common femoral artery disease that is significantly diseased. These are reasons why we need alternate access sites. I evaluate with digital subtraction angiography to see the inflow and the outflow to help me identify the best approach for tackling these patients' CTOs. So if you look at crossing strategies, Dr. Banerjee published a paper looking at various strategies for CTO crossing. This is analogous to our coronary CTO crossing algorithms. But I will say that if you look at CTO caps, Dr. Saab published something called the CTOP classification. If you look at the concavity or the convexity of a plaque, you can address whether or not you'll have a higher success of crossing from an antegrade or retrograde, or perhaps if you need a combined antegrade-retrograde approach. And this is classified as CTOP 1, 2, 3, or 4. CTOP 2 and 3 typically requires an antegrade-retrograde approach. If you look at the least common, it's CTOP 3. But I utilize this sometimes on angiography because if you can see the cap, you'll know where you can enter, either from above or below more easily. And of course, nothing is ever easy because we encounter a lot of roadblocks along the way. Calcification is a barrier for successful crossing. So when I started to learn the CTO crossing strategies, I will say that, there were so many of them. But what I did was I learned a few and became very good at a few. I tried to stay intraluminal as much as possible. I find that the CART, the controlled antegrade retrograde tracking, and reverse CART are very successful techniques, and we use a lot of extravascular ultrasound to help us cross. Guide wire selection is critically important. We have many different fundamental building blocks of guide wires, such as core diameters, coatings, core material, coils and covers, tapers and grinds, and tip styles that we should all become familiar with as we do CTO crossing, because this will ultimately be a delineation of whether you can have success or failure in CTO crossing. So if you look at long SFA occlusions, here's a patient with a toe ulcer, Rutherford 5. The patient had an SFA occlusion right at the ostium. You do not see a nub. We cannot see where the SFA origin is on angiography. So we assess the distal vasculature, preparing for possible retrograde approach. You can see there is reconstitution in the popliteal segment, and infrapopliteal flow is patent, so we do have access potentials from a retrograde approach. How do I cross into the CTO cap that I cannot see? Extravascular ultrasound. Here's a case where you can see the common femoral artery, the SFA, and the profunda artery, and you can see me penetrating the cap of the SFA that is not there. And from there, I'm able to cross using, this is an Asahi crossing catheter where I'm using orthogonal displacement of friction to cross a cap, but I'm not going blindly. I'm using extravascular ultrasound to keep me within the lumen of the vessel. And however, it's not always successful to re-enter into the true lumen. As you can see here, I've crossed into the P2 segment of the popliteal artery. The number one rule is to not cross further distally into the popliteal and extend your dissection. So this is where I stop the re-entries and I come from a retrograde approach to try to recanalize the SFA popliteal segment by minimizing the amount of dissection. Here, I was able to perform a CART procedure and essentially cross, you can see on the right-hand slide, my antegrade wires crossing into the true lumen of the popliteal. Then I performed laser atherectomy. I'm able to treat the vessel with drug-coated balloon technology. And after intravascular ultrasound, we felt we had a reasonable result and were able to leave the patient who did quite well. Intravascular ultrasound, I will say, has been highly valuable to us in America. It has allowed us to accurately size vessels. Oversizing vessels can obviously cause injury. Undersizing vessels with drug-coated balloon technology can lead to undertreatment of the vessel. There are abilities to assess plaque morphology. If you believe in atherectomy, which atherectomy tool is best for that lesion. Certain IVUS characteristics can help us understand dissections, reentry points for helping us to determine where stents should be placed. And also ChromaFlow can also assist in that as well. Of course, there are some cons, and that's cost and time. But I will say that over time, that as we've utilized intravascular ultrasound, the time commitment has become less and less. IVUS has been wonderfully important in understanding vessel size. This is an old supercore stent placed in an SFA. I've treated this patient multiple times with laser atherectomy and balloon angioplasty, unable to dilate the lesion despite multiple aggressive attempts. And I will tell you that in this scenario, I cannot make this vessel any bigger. This is one scenario where I will say, after looking at IVUS and looking at my angioplasty and all my attempts, that femoropopliteal bypass can be considered in this gentleman, and I think it may be a good option. So we use laser atherectomy quite commonly for crossing complex lesions. This is a patient with an occluded iliac artery down to the popliteal. It's a patient with ischemic cardiomyopathy, not a candidate for any bypass surgeries. This patient had stents that were placed for limb salvage in the past, and you can see he has reconstitution faintly distally in the popliteal segment. Unable to cross the vessel from the top with a balloon and a wire. So what do we use? We use laser atherectomy, turbo power laser to help us guide by leading with the laser through the stents. And you can see I'm able to recanalize I'm able to cross into the popliteal artery safely with a wire. From there, we're able to perform balloon angioplasty, drug-coated balloon technology, and revascularize this patient's leg. This is a patient that Dr. Walker probably knows quite well. I was a fellow of his when we worked on this patient. This is where I learned the power of the turbo power, crossing chronically fractured stents. This is another patient who was a limb salvage patient, did not have any bypass conduits. but he had a nitinol self-expanding stent because that was all that was available at the time. But over years of torsional force that causes a fracture, crossing it was quite challenging, but with a laser, you can see you can cross the interstices of this fractured stent quite well. We were able to place a supera stent within the fracture zone. We use drug-coated balloon technology, and this patient has been doing quite well for a long time. Re-entry tools, we have multiple re-entry tools in America. Pioneer is one that has lumovascular ability. You can see where you're re-entering into the vessel. I will say that I rarely use re-entry tools. They're quite expensive, but there are certain times where I feel if I'm in a location where pedal access or tibial access is not possible, and I don't want to obtain that access, I find those are the only scenarios where I grab a re-entry tool. Here's a case where we have a challenging cap. You can see a proximal SFA occlusion. I use Astato wires. I use the back end of a glide wire. I could not re-enter into the true lumen of that small short cap, but I came retrograde to see if I can cross from a retrograde approach. Could not do it. And so what do? We use laser atherectomy to basically bust the cap. Just a short little segment. You can use a laser and then you cross and the procedure's finished. Here's my final case I'm going to show you. This is a patient with critical limb ischemia who had bypass surgery, femoral-popliteal bypass, previous endovascular interventions. You can see they placed, this was not done by me. These are self-expanding stents placed into the aortoiliac segment to revascularize that segment. This patient was occluded from the ostium of the SFA. Again, we do not see a nub of the SFA. You can look at the inflow and outflow. There is reconstitution downstream in the P2 segment with some good infrapopliteal vessels. So again, this is a case I cannot come up and over from a groin approach. I use radial access. I came from a left radial access. I knew that I could not utilize all of my tools because we do not have them available from the left radial, such as atherectomy and certain stents. So I use tibial radial access. I'm able to cross by dissecting down the SFA. I use extravascular ultrasound again to help me identify the nub of the SFA. When I cross through from the top, I'm able to then come retrograde from a posterior tibial access. I'm able to dissect from a retrograde approach. And at that point in time, when I get close with my wires, I'm able to then perform a reverse controlled antegrade retrograde tracking procedure. The balloon is on the antegrade wire. And from there, I'm able to recanalize the vessel from the retrograde wire. I'm able to externalize the wire, perform laser atherectomy. I did from the tibial access using a slender sheath. However, this is the anastomotic site of stricture. I could not dilate it. I used high pressure balloon inflation. I used cutting balloon inflation. It would not crack. And at that point in time, the number one rule, in my opinion, is not to put a stent in this case yet, because the restenosis rate would be high if I cannot dilate that vessel. So at that point in time, I stopped. You can see the non-dilatable portion of the vessel on the IVUS image compared to the reference vessel, severely stedosed. I knew this patient was going to come back, but I got the patient out of trouble. I revascularized the proximal SFA, but 3 months later, she had disabling claudication. She did quit smoking, which was she was congratulated for. But I brought her back, and you can see the severe stricture in that distal anastomotic site. So in this case, I do not have the image of it. I use laser atherectomy in conjunction with contrast administration to create a cavitation, somewhat explosion, to help dilate that vessel better. That allowed me to use a cutting balloon angioplasty, dilate the vessel. I'm able to deploy a supera stent, which has great radial force, and ultimately then revascularize this patient. So in conclusion, I will say that we have to choose a strategy for complex SFA popliteal disease that is best for the patient, whether that's endovascular or whether that is surgical. And I feel like the decision should be based on local expertise. We need to plan a strategy to achieve a successful revascularization. Vitally important to understand the tools of the trade and how to effectively utilize them. And I will say understanding CTO crossing strategies is important, but get familiar with a few, become good at a few or excellent at a few, and that'll go a long way in treating our patients. Thank you very much. Appreciate it.
Thank you, Pradeep. That's a great presentation.